Hello and welcome everyone to TMA's Ask the Doc webinar series. I'm your host, Rachel Bromley. I am TMA Senior Manager of Patient Education Support and Advocacy, and today we have the honor of hosting Dr. Floranne Ernste. Dr. Ernste is a rheumatology specialist in Rochester, Minnesota, and has over 19 years of experience in the medical field. Dr. Ernste has extensive experience in rheumatologic muscular diseases and osteoporosis and screening. She graduated from East Tennessee State University, James H. Quillen College of Medicine Medical School in 2003. She is affiliated with Mayo Clinic Hospital St. Mary's campus. Dr. Ernste also serves on the medical advisory board for the Myositis Association. Dr. Ernste, welcome and thank you for being here. If you have a question for Dr. Ernste, please type it in the Q&A box at the bottom of your screen. Before we start today's Q&A, Dr. Ernste will take a few minutes to share her work. So, Dr. Ernste, welcome.
Hello. I'm
Hello.
delighted to be here this evening participating in the webinar series. My areas of clinical and research interest involve taking care of patients who have polymyositis, dermatomyositis, the anti-synthetase syndrome, necrotizing autoimmune myopathies, including the statin-induced myopathies, and inclusion body myositis. I also take care of patients who have an overlap myositis, such as scleroderma overlap with myositis. Over the last few years, I've been involved as an investigator in treatment trials for dermatomyositis and polymyositis patients, and I have collaborated with several neurologists, physiatrists, patient representatives, and other rheumatologists in developing guidelines for exercise therapy and myositis. I'm also involved in studies involving describing the disease characteristics of patients who have myositis. My interest also involves teaching the next generation of physicians about rheumatology with an emphasis on myositis. So thank you for having me this evening.
Well, you're welcome. We are happy to have you, and thank you for the important work that you do in your field. It's just so critical, and we really appreciate you taking the time to connect with patients. And so let's go ahead and get started with our Q&A. The first question I have is from a newly diagnosed with myositis patient. This person has a biopsy scheduled in August, and so they don't know what type of myositis they have yet, but they're just wondering, what are the main first or most important things that you tell a newly diagnosed person?
Well, I have to say the first thing I say is hang in there. It's going to be a long journey with you and your rheumatologist or neurologist. It really depends on the type of the myositis that's diagnosed, because that tells us so much information in terms of what to do for treatment. And sometimes there's more than just the muscles involved. It could be other organ systems, such as the lungs or the skin or the heart. So it's important for your provider to understand what all is involved, and then they can talk to you about what to do next for treatment. So generally, I start people right away on treatment as soon as I know how much inflammation's there in the muscle biopsy. And it all depends on who that person is when we decide what treatments to start. So these treatments involve immunosuppressive therapies such as steroids like prednisone, methotrexate, IVIG, azathioprine, and such. But again, it really depends on the patient. The other thing I say is to make sure that you see someone like a physiatrist or physical therapist to, as soon as your doctor says it's okay, to get started on an individualized physical therapy program, because you want to keep that strength up. And if you've lost a lot of strength, getting started on gentle range of motion, stretching exercises and strengthening exercises in the muscles that are affected is very important in a newly diagnosed myositis patient.
Thank you. We're going to start with some polymyositis questions. And
Okay.
I have emailed questions that have been submitted via email. And then we also have the ones that will be coming in through the Q&A box. So I'll be going back and forth. So it may seem like I'm jumping around, but I'll try to stick with disease types first.
Okay.
So this person was diagnosed with PM in 2010. They've been treated with methotrexate and prednisone because they also have other organ issues related to the disease, heart, lungs, kidney. Not having any problems with the meds affecting liver, but what other meds can be used? And you may have already mentioned them, but if you could briefly go back over them.
So other medications that can be used besides methotrexate include azathioprine, mycophenolate mofetil. Those are the two other ones, probably the more common ones. If you're looking for a medicine that is not going to affect the liver probably as much as methotrexate, that would be the mycophenolate mofetil, also known as Celsip. However, that medication does suppress the immune system more than the methotrexate. So you could be at risk, higher risk for infections with that particular medication. There's also IVIG that I've used to treat polymyositis, and that one is not common to affect the liver. And I've used it in addition to other medications such as methotrexate.
Okay, thank you. So this person also has polymyositis and they were on prednisone and they're decreasing it. Is the next treatment option automatically IVIG, or would you do something else before then? I guess it probably would just depend on the patient and what their file looks like.
Yes, it really does depend on the patient, but things that the provider looks for would be, as the prednisone is being slowly decreased, the strength is measured on follow-up appointments. The CK levels are 2, which are the muscle enzymes or other muscle enzymes besides the CK, and whether there's other manifestations of the myositis that could be affecting other organ systems, such as if the lungs are affected, is the breathing getting worse? If the joints are affected, is the arthritis getting worse? So it really depends on those organ systems too, in terms of then deciding what's the next best step in treatment. So IVIG can be used. It does help the muscles. It helps the skin. If there's dermatomyositis, but in polymyositis, the skin, it wouldn't be involved. Can also help with swallowing too, if swallowing is an issue. So that is a possibility. Other things I think about would be methotrexate. So it doesn't necessarily have to be the next step IVIG, maybe methotrexate, unless there's a concern of underlying liver or kidney disease or other concerns, and methotrexate then would not be used.
Okay, well, you mentioned methotrexate, and that was one of our other questions was, do you have any reservations about long-term usage of methotrexate?
Very good question. That's often a question that is asked of me, of my patients. And so it really depends on if there's any underlying disease, such as liver disease. So what can commonly be seen is actually fatty liver disease in the Western kind of half of the hemisphere because of the diet and such. And so people have elevated cholesterol that can lead to fatty liver disease. So if there's underlying fatty liver disease in somebody's on methotrexate for a long time, sometimes it can affect the liver enzymes, which they start to go up. So in that situation, I would limit methotrexate use, especially if liver enzymes are going up. However, if you're carefully monitored with the monitoring protocol that we use when treating a patient with methotrexate and your liver enzymes are normal and your creatinine is stable, then even if you use it for the long term, it doesn't necessarily mean that there's going to be some poor outcomes. In fact, I have many patients who've been on methotrexate for a very long time and have not experienced any significant side effects because they're monitored closely.
I was just diagnosed with PM this past April after having been almost entirely bedridden for 2 years. When can I expect to not feel fatigued all the time? Is that just a permanent symptom of PM?
That's a good question. So just being diagnosed with PM after being bedridden for 2 years, that's a long time, being bedridden. Over time, your muscles will start to get what we call deconditioned. So if you've been in bed or not exercising as much as you would normally exercise or whatnot, your muscles just are not as strong because of that. And so your muscles experience muscle damage over time. And now that you've recently been diagnosed, I'm sure you've been started on treatment. It does take quite a while to rehab those muscles if you had been bedridden for 2 years. So it's not going to be something you're going to notice probably in the next few months, perhaps up to a year. For example, to get back to where you were before 2 years ago, maybe sometimes even longer, and depending on what muscle groups are involved. But I would definitely ask your provider to see if you would need to be seen by a physical therapist. You may already be seeing a physical therapist. Just go ahead and work with the therapist in terms of doing exercises to strengthen your muscles, because that's going to be one of the most important things to get you turned around. Once you start moving better, the fatigue actually gets better. But that takes, of course, time. And sometimes our medicines can also cause fatigue. So if there's a medicine you recently started and then you feel your fatigue is worse, talk to your rheumatologist or neurologist about that. If you have other things going on, for example, some people have low blood counts and then they have fatigue, or some people have untreated sleep apnea and then they have fatigue, or some people have thyroid disease and then they have fatigue. So there's could be multiple reasons for fatigue, not only from polymyositis. So it's important to get with your provider to make sure all other reasons have been excluded.
Okay, we've got one more PM question, and then I will switch over to dermatomyositis. But this person has PM and wants to know, will the swelling in the feet ever go away? And will they ever get the feeling back in their fingers?
Okay, so swelling in the feet, so that can come with reduced mobility and reduced strength. And so the calf muscles are not as strong. And when the calf muscles are not as strong, they don't pump the blood as much as they should. And so you can get leg swelling from that. So I often do see that in people who are weak in their legs, get the leg swelling. And so the best thing is to exercise those leg muscles, but also use compressive stockings. There could be other reasons though for the leg swelling. So for example, if you've got varicose veins, and they're getting worse, that could contribute to leg swelling. If there's only one leg that's swollen and there's a lot of pain in that area, make sure you get checked out that it's not something like a blood clot. That's not common to see, but sometimes if you've been bedridden, debilitated, not moving as much, the blood can pool in your legs and cause swelling from that reason. And that potentially could be life-threatening. So just make sure you let your provider know. Leg swelling can come from chronic steroid use too. And so if the steroid dose maybe is too high or too high for you, you might want to talk to your provider about lowering that. And hopefully that helps with the leg swelling. Leg swelling can be from many things, just like fatigue. So I would expect that when your polymyositis gets better, you're moving better, you're more active, then that is going to circulate the fluid better from your legs up to the rest of your body. In terms of the hand numbness, that's not a common symptom of polymyositis. Hand numbness and tingling can be from other reasons. The most common reason is probably carpal tunnel syndrome, caused by swelling in the wrist, which pushes on the nerve in the wrist, and then you get the tingling. Some people get even weakness in the fingers from that. So I would definitely talk to your provider, see if there's some other thing going on, some neurologic issue causing the tingling in the hands.
Oh, that is so good to know. Okay, well, let's switch to dermatomyositis. And someone would like to know, have you seen any heart-related issues with DM?
The heart is not as commonly involved with in DM as opposed to other organ systems such as the lungs. I have seen heart involvement where the heart can get too big, something called cardiomyopathy. There, that's where the heart kind of gets like a balloon sort of, and then doesn't pump the blood out as well as it should. Or it can be something called or DM affecting the heart, causing myocarditis. And that's when there's inflammation in the heart muscle tissue itself. And so then the heart starts beating not regularly, and people get chest pain and other symptoms from that. Again, that's not common to see. In fact, it's more likely to occur in people who have another autoimmune disease, such as lupus, for example, or scleroderma, where they can more likely get issues with their heart conduction system causing a cardiomyopathy or enlarged heart. And then they also happen to have myositis. Um, so the heart is not as commonly involved in the dermatomyositis patients, but if it is involved, those are the two things I've seen with dermatomyositis. And then as you get older, as people get older, there's a higher risk of heart disease. If you've been on treatment with some NSAIDs, for example, for pain relief, that actually can elevate your heart issues and cardiovascular disease as kind of a complication of being on that particular medication over a long term.
Okay, we have another medication question by somebody who was diagnosed with DM 2 months ago. They're currently being treated with steroids and methotrexate, but their rheumatologist mentioned IVIG. Right now, this person has so much muscle pain. It's so bad that they can't even imagine doing physical therapy. And they want to know if they start IVIG, will their muscle pain go down? Will it improve?
Well, so muscle pain, it's sometimes more than just from muscle weakness. So if there's a lot of muscle, for example, if there's a lot of muscle pain and little muscle weakness, it might be from other things that cause it, can cause pain. So first, just to make sure there isn't something else that's a cause of the pain, whether it's something to do with some sort of medication, or maybe there's an underlying arthritis, inflammatory or otherwise arthritis. IVIG in and of itself doesn't help target pain so much, but more strength. Will help muscle strength. But downstream or indirectly, it can help the pain if the muscles are weak around the joints. So then that strengthens the muscle, and then the joints feel better. So in that regard, it can help pain. But that being said, people feel pain when they're not moving well anyway. They don't move well because they're weak. And if the IVIG helps the weakness and people move better after that, then that can help the pain. Pain is very complex. And so I would hope if there's any treatment that's geared at treating the underlying disease, like dermatomyositis, at some point it's going to help the pain. Maybe not right away, though.
Okay. What treatment would you recommend in DM for soft tissue calcification?
Okay, so calcinosis. Calcinosis can be very tiny in some areas, like some people just have a little dot of calcium right under the skin, or it can be really severe and affect large portions of the body, the arms, the chest, the thighs. So there's differences in the extent of severity of calcinosis. The calcinosis that involves just a small area of the body is actually easier to treat, I would say, than involving larger extent of the body. So if it's just right under the skin, it's just a small piece of calcium, there's actual topical agents that can be used. One that I have used is called topical sodium thiosulfate. That's in zinc oxide. And I write that as a prescription, and some of the pharmacies will compound it, make it. I know our pharmacy does here. And then it's sent out as a vial or a bucket of it, and then you can use it up to 2 to even 4 times a day. It's supposed to soften the calcium deposit. What about the larger calcium deposits? Well, those can be refractory, meaning can be harder to treat. In general, we say those calcium deposits are from inflammation that has not been adequately treated. And so then you get calcium buildup. So if you treat the underlying dermatomyositis with whatever treatment you're using, whether it's a biologic, IVIG, methotrexate, at some point that'll hopefully help reduce the calcinosis burden or the calcium deposit burden. There's been other therapies. There's a lot of literature out there about trying to treat calcinosis, but a lot of therapies that have been tried, such as the blood pressure medicines like calcium channel blockers, like diltiazem is one. And that's been tried, sometimes not very helpful, and other times maybe there could be a little bit of help, but it also lowers the blood pressure quite a bit. So then there are side effects from using that. There's other therapies that have also been tried outside of the immunosuppressants and the calcium channel blockers, such as the bisphosphonates. For example, Fosamax is one. Well, that one, we're not sure that could or could not work. So we don't have anything that strongly is out there saying this is going to work. Then there's experimental therapies out there too that haven't been generally proven to work, but they've been tried.
This next question may be for more than just dermatomyositis patients. You can let me know, but this person with DM asked, should patients be screened for cancer after being diagnosed? And if so, how often? And is a PET scan the preferred method for screening?
Very good question. That's a question that's often asked, not only by patients, but also providers in many different fields, including our field in neurology. As I am talking, I know that there are guidelines that are coming out from several groups and major academic centers that will guide providers in terms of how much to do to look for cancer. So in dermatomyositis, there is a higher risk of cancer, and it is generally in people who are newly diagnosed. So within generally the first 1 to 3 years. That being said, it is most often diagnosed in the first year of diagnosis of dermatomyositis if there is a cancer. And of course, not everyone's going to have cancer or dermatomyositis. It all depends on risk factors. And the single biggest risk factor is age. So age over what? Is it 40? Is it 45? Sometimes depends. If there's a family history of cancer in a first degree family member, for example, breast cancer, or ovarian cancer, then that risk is higher, or colon cancer, that risk is higher. And the person who's newly diagnosed in dermatomyositis sometimes doesn't even matter what the age is. So that could be a risk factor too, is family history. And then we look at, rheumatologists and neurologists will look at whether there are any blood tests that tell us that there could be a higher risk of cancer. And some people have antibodies they make that increases their risk even higher than somebody who doesn't have a particular antibody that's associated with dermatomyositis. So if there is a high risk antibody, then the general line of recommendation by rheumatologists and neurologists is go look for the cancer. So it could be CT scans, chest, abdomen, pelvis. Make sure you're up to date in cancer screening testing, such as mammograms, colonoscopy, pelvic exams, prostate exams, and in general, as a general rule. What about the PET CTs? Good question. In my practice, I have ordered PET CTs with newly diagnosed dermatomyositis patients. There could be barriers with insurance for coverage with PET scans because they are a lot more expensive. So that we have to keep that in mind too. And so sometimes it's not feasible to get a PET scan. However, a CT scan of the chest, abdomen, pelvis usually is very comprehensive enough to go looking for that cancer, unless the provider is worried or the patient is worried that it wasn't found, and then moving moving along and going to a PET scan may be the next best step. So how often to screen for cancer? That's another good question, and I don't think we have that figured out yet. Some people do once a year, will check for cancer until that 3rd year. Some people just do it right at diagnosis and not check again unless there are other high-risk features that come out.
Okay, we're still on DM and we'll move on to necrotizing after we ask the DM questions. This person has DM, but no scalp rash or irritation of any kind, yet they are losing so much hair. Her doctor says it's not normal. She's wanting to know, is it because she's taking IVIG? Is there something she can do to stop the hair loss?
Okay, so hair loss and dermatomyositis generally follows after there's a rash on the scalp. So that's usually when I'll see the most hair loss is when I'm seeing active lesions, skin lesions on the scalp from the dermatomyositis. If there are no active skin lesions on the scalp that could explain the hair loss, then I look to see, are there any medicines or anything in the endocrine system that could potentially be affecting the hair. So medicines, for example, one is methotrexate. It can cause hair loss. Not everyone gets it, but some people do. What about endocrine? So the thyroid, of course, can also contribute to hair loss. If you're not on methotrexate and there's no other medicines that could do it and the thyroid's okay, then it might be worthwhile to see a dermatologist, because a dermatologist then can diagnose for sure what is the cause of that hair loss. Some people who have gone through a lot and they were newly diagnosed with this dermatomyositis or some other, even any other disease that's chronic and causing a lot of inflammation, their body, just because of the stress, you lose all the hair from that. And then once that stress is under better control, the hair starts to grow back. So that could be something that could be going on. It's called telogen effluvium. But that often I'll ask the dermatologist to help me out too, to say, hey, there's hair loss. It looks abnormal. I don't know if I can explain it by dermatomyositis. Is there something else going on?
Okay. What do you suggest for itching?
So the itch can be very frustrating, especially if there's active lesions from the dermatomyositis. There's different topical therapies, different steroids that if you use it can help with the itch. Some topical therapies are a little stronger than others that could be helpful. And sometimes those therapies are not helpful, and some patients telling me they burn too much. Some people require an anti-itch kind of medicine to try it, as long as it doesn't interfere with any other medicines, because there can be interactions. One anti-itch medicine that I've used is called Vistaril, but it can cause sleepiness and sometimes even other side effects, and it can interact with some other medications, so you have to be careful about that interaction. So that's one medicine. Sometimes it's really hard. Some people use topical Benadryl, for example, even oral Benadryl to help with the itch, but recognizing there could be the side effects of sleepiness. You don't want to use too much and then you get really sleepy, or some people even get confused. Otherwise, controlling the underlying skin disease better, whether that's with IVIG or other immunosuppressive agents.
Okay. What is the best anti-inflammatory medication with the least side effects for DM, in your opinion? Oh, you smiled.
I think that's a loaded question. I always tell people every medicine has a side effect. And sometimes,
well, because side effects depend on the person. You can't
say, sometimes side effects happen and you don't even realize it. It's so variable in some people that some person can get a side effect that's not well described, and then it happens, well, it's still a side effect, even though it's not well described. So sometimes things happen you can't predict. So I wish I could say there was only one medicine and here you go. That's an anti-inflammatory. It is going to help for sure, and there's the least side effects, because if I say that and someone says, well, wait a minute, no, I got these terrible side effects, you were wrong. So I can't pin down one particular medicine. I will say that the medicines that have the strongest effect on the immune system, so like the medicines that are strong immunosuppressants, can lead to infection risk, a higher infection risk that you don't see with the more common standard medications. So that, if there's a serious infection, like a serious pneumonia, that can really complicate matters. So I say, well, if we really have a strong justification, we're going to use something strong, just recognize there's going to be more side effects. And then the milder medicines, there's maybe not as many of those kind of side effects. However, something still can happen. Every medicine we use in rheumatology, there's some sort of monitoring protocol. We know enough about our medicines that we're going to watch you and make sure that you don't get any of the common kind of side effects described. I wish that was an easy. I wish I could give an easy answer.
I know, it would be so nice for our patients to have, one thing that's just a definite. But often it's trial and error, I guess, so. All right, so let's see our last question for DM, then we'll go on to NM and then IBM. Does dermatomyositis affect the gastrointestinal tract in adults? And if so, how?
That's a very good question. Yes, it can affect the gastrointestinal system in adults. So one thing that can happen if there's really active muscle involvement is it can affect the swallowing function. And because the muscles at the top part of the throat, of the esophagus, are the muscles that can be affected by the dermatomyositis from inflammation. So people who have that complication, they can't swallow their food very well. For example, they have to take very small bites and swallow very carefully with like tucking their chin and taking a sip of water after every bite and swallow. So that the upper part of the GI system can be involved. Dermatomyositis can also involve the intestines. Not common to see, in fact, is probably more common in juvenile dermatomyositis, where it can affect the blood vessels in the walls of the intestines. And if the blood vessels are affected by inflammation, it can possibly affect the lining of the intestine, where then the worst case scenario is that intestine gets an ulcer, and then the ulcer can progress and get bigger and bigger, and then that can cause complications of even a perforation, where part of the intestine, there's a hole that happens, and that is an emergency. You have to go into the hospital if that happens. So that's not a common involvement by dermatomyositis. Indirectly, because you're on medicines like prednisone that can cause inflammation of the stomach lining and gastritis, that can happen because you have dermatomyositis and then you're on treatment for dermatomyositis. So that's an indirect involvement of the gastrointestinal system. Some people who have myositis and they have another autoimmune disease, sometimes I see scleroderma myositis, the very bottom of their food tube, the valve is floppier, and so they could have a higher risk of heartburn, and then heartburn side effects come from that.
Okay, we actually have someone who has raised their hand. I don't typically take questions that way, but just in case you're unable to type it into the box, Shirley Flaherty, I'm going to allow you to talk and you can ask your question. Shirley, you're muted. I'm going to ask you to unmute. Oh, what's your question, Shirley? Okay, we're having a hard time getting a hold of Shirley, so we'll just go ahead and go back to our questions. All right, so let's go to necrotizing myopathy. What research is being done in the area that might reverse the effects of NM, if any?
Research, there's ongoing research in necrotizing myopathy. Most of the research is actually trying to describe it in terms of how to compare it to the other myositis syndromes. And reversing the effects, I would assume, means the damage that's done then to the muscle tissue. Unfortunately, necrotizing myopathy can be quite severe, and if not treated or left untreated or inadequately treated for quite some time, can actually cause damage that in some people I've seen not reversible, unfortunately. And so even with treatment, ongoing treatment, they continue to have some weakness in the muscle, that are the muscles that are involved by it. In terms of treatment of necrotizing myopathy, I don't know at this point in time if there's ongoing treatment trials for reversing the effects of necrotizing myopathy. I would have to ask some colleagues of mine in neurology if they're involved currently in the treatment for necrotizing myopathy. In general, what we do for necrotizing myopathy is we treat as aggressively as we can upon a new diagnosis of it, so that there isn't damage that occurs later from not being treated.
That was an additional question. What are the best treatment options for this diagnosis?
Oh, that's a good question. There's a lot of different ways to treat it, and there's even differences among experts in how they treat necrotizing myopathy. I think that it's some myositis kind of, it represents a category of the myopathies that we're still learning even today. So as we've found that there are some antibodies that are associated with it, I'm sure there are more that are not yet discovered that will be discovered at some point. So we're still, as rheumatologists and neurologists, still learning a lot about it. So when we are learning, it's a trial and error almost way of learning. So in general, the experts will say it does require probably at least 3 immunosuppressant agents to try to get it under control. Now, having said that, I do have some patients only on one, and they're doing just fine. But others do require IV therapy. So the same treatment we use for polymyositis and dermatomyositis, we extrapolate that and use for the necrotizing myopathy patients. For example, if it's methotrexate, we'll start with methotrexate. If it's azathioprine, we'll use that. We'll use mycophenolate mofetil, also known as CellCept. If we've used that and their side effects are just not as effective, we'll add on other therapies. A lot of experts actually start with IVIG, and I have too, with necrotizing myopathy, because people respond quicker to the IVIG therapy and then add on other immunosuppressive therapies. We're also looking into whether B-cell depleting agents such as rituximab is helpful for necrotizing myopathy, and I know some experts have used rituximab in addition to the other immunosuppressive therapies for treatment of necrotizing myopathy. It's also important to do physical therapy as much as you can. I know it's hard, especially if you're very weak, but trying to just get those muscles mobilized, the best thing you can do, because even at the muscle tissue level, if you exercise, it's going to help regenerate those muscles.
Yes, that's the other question we got, was about an exercise regimen. And I was wondering, does the regimen for exercise change depending on the type of myositis you have?
Yes, it does. So there is inclusion body myositis, where some people have involvement of their fingers and their wrist with inclusion body myositis that you don't have with necrotizing myopathies or dermatomyositis even. It's not common, at least, to see. And so there is very much a difference in the type of exercises among the different kinds of myopathies. And it also depends on the patient. So whatever muscle group you're weak in, we're going to try to target that with exercise. And so the individualization of the program is very important and is key to meeting goals, strength goals. So for example, with necrotizing myopathy patients, I've seen the hip muscles, the thigh muscles, the backside muscles to be very weak, even more weak sometimes than the arms. So we'll focus on therapies to build up the strength of those muscles. And then in the inclusion body myositis patients, if it's the hand and the wrist, and then it's doing exercises to try to keep the mobility up in the fingers, the hands, and the wrist. Sometimes it's the foot and the ankle that's really weak in inclusion body myositis. The physical therapist and physiatrist also can do occupational therapy, and an occupational therapist can provide adaptive equipment that may be needed, which is very important. And some people, even braces, such as for the ankle, is important to stabilize the foot so it doesn't drag when trying to walk.
Okay. What percentage of mobility can you expect to return if you have anti-SRP autoantibodies with necrotizing autoimmune myopathy and you have lost a lot of muscle strength?
So the necrotizing myopathy patients in general have a more severe course because so much muscle tissue can be involved, and it tends to be the muscles that hold the body up and the legs up, and using the legs when walking. Some people have kind of a waddle sort of gait because they're so weak in their hips, and it depends on how much damage has already been done. The SRP antibody is associated with refractory necrotizing myopathy, and in those patients I often have to use a combination of IVIG and other medications to help, because if I don't, even if I take one away, sometimes people flare, their muscle enzymes get worse, and so I try to keep them on a stable regimen and then work with therapy for them. If there's, again, as I said before, if there's already been damage, sometimes it's hard to get that muscle back. And if you do, that's good, but it's going to take time. Sometimes what I'll do is get an MRI of the affected muscle just to see how much of the muscles have atrophied, have become smaller. And if they have substantially become smaller, then we might have to revise goals. For example, getting back to full strength before the diagnosis may not be something that could be feasible, but perhaps getting as much as you can to a certain point, recognizing that there's already been atrophy that's set in. When there's atrophy, the muscle tissue gets replaced by fat. And the fat is hard because then once it's already in there, it's hard to regrow some of that muscle tissue back. But I wouldn't let it get me down. I'd still keep, of course, exercising.
With NM, is there any possible genetic link for who will get it? For example, a family on Lipitor, if one member gets it, is it likely that others will?
That's a good question. So that would be people who have been on a statin and then they get a necrotizing myopathy. There's ongoing, I believe, studies looking into that even now. But in general, we do think there probably is a familial risk. And there are genes that have been described that have been linked to the particular myopathy that can be seen with use of statins. So if you have a first degree family member, immediate family member, and they've had trouble with the statins, you might have the same, but it's not guaranteed because not everyone inherits the same genes, and the genes don't always get turned on for some reason. So it's a little bit more complex than that. But I would say there is a genetic association. Sometimes the association is not very strong in some families, and in others it is stronger, depending on the gene.
I'm just reviewing the Q&A box.
Okay.
Someone going back to PM, but this is probably a question that anybody wants to know, regardless of their type of myositis. How normal of a life can I expect to have with treatment, and should I expect a shorter lifespan?
So with any myositis,
They particularly have PM. Is there
okay.
differences in lifespans depending on what you have?
I think one predictor is if there's a major organ that's involved. So for example, in the anti-synthetase patients who have lung disease, and the lung disease continues to progress, that potentially could affect the lifespan. However, if there's no major organ involvement and it's just polymyositis, then we understand the person to have probably a normal lifespan. And now some medications can be associated with causing severe infections, and then the complication from that potentially could shorten the lifespan, but even it's not that common at all. So shortening the lifespan shouldn't worry too much about that. We actually think that isn't the case unless, like I said, there is some other organ that's majorly involved. Now for the polymyositis, in terms of regaining the quality of life, so that's very important. We hope that over time that does happen with treatment. And so continuing to work with your provider about making sure you're on the right treatment, because I have patients who lead completely normal lives and they're on treatment, they're in remission on treatment, you wouldn't even know they have it. So that there is a potential to get there to that point, but everyone is so different. And there could be other factors. For example, treatment that one person tried, maybe another person just cannot tolerate and can't use it.
This person has NM. They are tapering prednisone and their sugar goes extremely high. Is there a connection?
So prednisone in and of itself can make the sugars go high. It's just a very common side effect with prednisone. Now, some people are predisposed to diabetes, and that actually diabetes is highly genetic. And so prednisone can indeed cause a steroid-induced diabetes. So it may be over the long term. I'm not sure how long that person had been on steroids, but it can be a cumulative effect. And so oftentimes another blood test called the hemoglobin A1C will give us a better window in terms of if it's high. The sugars have probably been high for a long time, for at least 3 months or longer. And so that person may be noticing it just as going down on the prednisone because now maybe the sugar is being checked more. I think it's important to follow up with your primary care provider, potentially even seeing someone in the diabetes field, such as an endocrinologist may be helpful. But the best thing to do is to try to get off prednisone if the sugars are too high. So trying to pick another medicine to replace the prednisone.
Okay. Someone has asked how their providers can view this webinar. It is being recorded and you can keep an eye out on our YouTube, the Myositis Association channel, for when it gets loaded, and then you can share that link with your provider. You can also email me, rachel@myositis.org, and I can send you the link once it's loaded. Not all questions are able to be answered, but we're doing the best we can with what we have. Let's see. We've done NM, and I want to let everybody know that if you missed it, just this past Tuesday, we had Dr. Andrew Mammon on for just a necrotizing myopathy session, and that will also be put up on our YouTube. So if you missed it and you have NM, you keep an eye out on our YouTube channel for that one as well.
I have to say he knows very much about necrotizing.
Oh yeah. Right. Okay, so let's go to some IBM questions, and then we'll have some more general questions before we go. We have about 12 minutes left. Let's see. Sometimes your question can't be answered if it's very particular to your situation and doesn't apply to more people. And sometimes your question won't be answered if she's already talked about it. Okay, so let's see. This person, we haven't talked about CK numbers. She went from 117 last month to 241. It's been increasing over the last 4 months. The rheumatologist says her strength is excellent. She exercises 3 times a week, but she's worried that she's exercising too much, and that's why the number has been increasing.
Okay, so you said 117 to 241?
Yes, that was
Okay.
from last month to 241 today. I
Okay.
mean, I guess the overall question is, can exercising too much be harmful?
No. So there is differences in um, the CK if it's checked periodically. What I have seen is there could be fluctuations in the CK level according to activity. So it depends on what kind of exercise. So there's obviously some exercise like marathon running. So very intense, heavy aerobic activity can drive the CK level higher versus not as intense activity. Walking briskly around the block, for example, and you don't expect maybe the CK level to be high. I have observed CK levels to remain high after an exercise activity, but it depends on what the range is. So what's the difference between 1 month and the next month, for example? So the 117 to the 241, I agree, I would not be concerned about that. If it's 117 and now it's 800 the next month, that's a concerning rise. And it is not likely due to exercise, but something else, maybe inflammation coming back. Maybe something was changed with the medications, for example. Um, so I tell people, don't worry about the CK if you're seeing that kind of fluctuation. Sometimes I don't even measure the CK as often as every month if I think that the patient is stable, because it's not necessary. And in some people, it might cause some stress to see a CK going up, because you obviously want to see it go down and stay down and don't go up anymore. So it may not always be useful to be checking it as often once that you are in remission or stable on your medications. There can be an enzyme leak. So CKs can leak out of muscles that have been damaged previously from inflammation. And so if that person is exercising 3 times a week, don't stop the 3 times a week exercise, but just recognize that that can happen. And overall, you're doing good for your muscles because you're building up your muscles. Exercise.
Okay, this person has IBM and wants to know, and you have mentioned to me that you do see some IBM patients. So can a rheumatologist help a person with IBM, or is it best to just see a neurologist?
That's a good question. It really depends on experience. With some rheumatologists not having that much experience and neurologists having more experience. So it really depends on the provider first. I think providers who work in large academic centers who are used to seeing a high volume of patients probably will have more experience depending on how long they've worked at that center versus someone who does not work in a large center and doesn't see a high volume of patients. So you're more likely, if you go to a large center and you're going to see a rheumatologist, that they're going to have that experience. Same thing with a neurologist as well. Neurologists and rheumatologists often share patients in the myositis world, including inclusion body myositis. Either or is what I would say, but again, depends on that particular person and what their experience has been. The neurologist, they also see other types of non-inflammatory myopathies, such as muscular dystrophies. And I work very closely with our neurologist here. And so sometimes I will refer a patient who had one diagnosis and it ends up being another diagnosis because they thought to look into other kinds of non-inflammatory myopathies. And so that's very helpful.
Okay, we are getting closer to time. Assuming that a GGT blood panel was done ruling out any issues with liver function, why is it that AST and ALT levels are affected in myositis patients when there are no problems present with the liver? Are you familiar with any research done on this?
That's a good question. It's actually one of the teaching points I have for many of the residents and medical students. So the AST and the ALT are also muscle enzymes. So they are also high. They can be, not always, but they can be high in people who have myositis. And as long as the liver's checked out and the liver's normal, then we can rule out a liver as a source of those levels of the AST and the ALT. So there's actually 5 muscle enzymes. There's the CK, that's the one that's the more specific and more often checked muscle enzyme in myositis. Then there's the aldolase. Then there's the AST. Then there's the ALT, and there's the LDH. And some experts will follow quite a number of them, depending on the person, while others will just follow the CK. But we, in general, know that those 5 enzymes can be high in people with myositis, particularly when they're initially diagnosed or newly diagnosed, and before they start treatment. However, even on treatment, and it's not a liver problem, and their myositis is flaring, sometimes the AST can go high or the ALT.
Okay, someone asked about the turnaround time for videos going up on YouTube. It's usually 2 weeks. We have to do some editing before we can get it up there. How can one have normal DEXA, but still keep having broken bones? And if so, should someone go ahead and take Prolia?
Okay, so this is more probably for an osteoporosis question. Okay.
Okay.
Depends on the DEXA scan itself. So I would assume the accuracy of the DEXA scan, but there is an ability to calculate risk for fracture based on the scores on the DEXA scan. And it takes in all these variables, such as, are you on steroids and how much? Do you drink alcohol and how much? Is there a family history of osteoporosis? That's all plugged into an equation that we call the FRAX score. That's the FRAX. So sometimes people will have so-called normal DEXA scan, meaning not showing osteoporosis, but they have an elevated FRAX score, which then predicts what your risk is of having a fracture over the next 10 years. And providers usually know, based on the score, what that risk would be and still treat for osteoporosis based on the score results. I can't really comment on the Prolia. Everyone is different in terms of what is the first medicine to start for treatment of bone disease. So Prolia is one that perhaps is not always the first line treatment. Generally, it's something like a bisphosphonate in addition to calcium and vitamin D, unless there is a concern about using a bisphosphonate. And then the Prolia then can be used. Now, just because the DEXA scan is normal and you're having fractures, it also depends on what kind of fractures you're having. So defining where the fracture is and what kind of a fracture it is can also point into what may be the cause of it, of getting fractures.
Since you're talking about fractures and people with IBM are prone to falling, and falling can result in broken bones, is a FRAX score something that's useful to IBM patients, or is it just if you've been diagnosed with osteoporosis?
At any patient who is on chronic steroids, generally we don't put IBM patients on chronic steroids, although some people are still on it and need it and feel like they do. So if you're on chronic steroids, then we will generally use that FRAX score. It doesn't matter what kind of disease you have, it's chronic disease requiring steroid therapy.
Okay, as a last question, and I'm sorry to those we didn't have enough time to get to all our questions. And remember, we had questions that were submitted by email too that we needed to put in there. But my question to you, Dr. Ernst, is when you have a patient who is really feeling down about their diagnosis, what words of hope or inspiration do you have? If we could possibly leave on a high note, that would be wonderful. I mean, I know you said hang in there, but.
I wish I can give a virtual hug to everyone right now. Yeah, it's remembering what is important and putting priorities, and your priority is your health, of course, and regaining your health, and working with finding a person who's going to be right there with you and responsive to your needs and going to walk with you on the journey of getting you better. And so words of hope, every day is a new day. There is always a chance to regain something, and keep your spirits up, of course, all the time. As lean on your family for support, or friends for support, and both. And explore things that you haven't done before. Take up some new hobby that brings you joy.
Thank you so much for being here, Dr. Ernst. We really appreciate you. And we look forward to doing more collaborations with you. This has been great. Thanks.
Thank you so much for having me.
All right. Well, thank you for being here for today's Ask the Doc webinar. I'm sorry to say that's all the time that we have. Please tune in for the next Ask the Doc series webinar, which airs on Thursday, August 18th from 6 p.m. to 7 p.m. Eastern Time, when we will host a panel of pulmonologists, Dr. Sonia Danoff, Dr. Robert Hollowell, and Dr. Shalonda Johnson. TMA also invites you to participate in our 2022 International Annual Patient Conference. It will be held in person in Orlando, Florida, but there will also be a virtual offering for those of you who cannot travel. You may register for the event on our website at myositis.org. We hope to see you there. For TMA, I am Rachel Bromley. Good night.